Hi, my name is Lauren. Today we're going to talk about the non-invasive pressure ulcer prevention protocol. The objectives for this educational presentation is, upon completion, the learner will be able to discuss the non-invasive ventilation protocol and provide care associated with this protocol. There are several non-invasive interfaces that are used at CCHMC. There are lots of nasal masks, full face masks, and also a ram cannula that is used for our younger population. We quickly try to get to a nasal mask if we can. We do have a full face shield as well that we have used. We have the smaller sizes and the larger sizes for both of those. The ventilators that are used for non-invasive ventilation are mainly the Servo-I and the Trilogy. We also do have V60s, Focus, Synchrony, and Cardinal machines. Mask fit and leak tips for non-invasive are very important. We're going to go over a few. Mask fitting exercise would be to place the mask on the patient's face, turn their head gently from side to side to try to adjust the equipment and minimize the leaks. We also have some plastic reusable sizers that help determine the size of the mask so you can get the correct size mask for the patient. The mask seal, again, does not have to be perfect. The non-invasive ventilation devices are designed to make up for small leaks, but patients aren't going to tolerate leaks blowing in their eyes. The leak should really only be near the bottom of the mask. We expect the mask to leak slightly though. It's important to not over tighten the headgear straps. Tighter is definitely not better. We expect minimal leaks, so just trying to reposition would be the first option, repositioning the mask and the headgear before tightening the headgear and straps so tight where it's pushing and denting the skin. Mask leaks are due to the patient moving their head or changing sleeping positions. Try to pull the mask away from the patient's skin, allowing the cushion to reinflate to minimize the leak is also a good tip. We do have some leak parameters that are important. The best leak, the goal leak we like to say would be 7 to 30 liters per minute. Anything less than 7, the mask is probably too tight. Anything greater, there's probably a larger leak, but they are acceptable up to about 60 liters per minute, especially on the Servo-I. A lot of our masks can go up to 80, and they're pretty acceptable. Really just depends on which mask the patient is on. Next, we'll go over the non-invasive protocol. We want to clean the mask every day with soap and water. Remove the mask every 4 hours to provide mouth care and assess the patient's skin. Alternate masks every 4 hours between full face mask, face shield, and a different mask, or nasal prongs if appropriate. We try not to use anything in between the patient's face and the mask unless redness develops, or the exception of a high-risk patient such as a bone marrow transplant patient or a patient with underlying skin sensitivities. If redness develops, we use hydrogel dressing, or called Caradress. We cut that out around where the BiPAP mask would be indenting or causing redness, and then cover that with Methylex Light because the care dress is real sticky. So basically you'll remove the plastic from one side of the care dress, which is like a sticky gel. You'll want to put that down on the patient's skin, and then place the Methylex Light on top of the other side where the plastic is still on. It's important to change that out every 4 hours because the care dress dries out and can actually cause more issues if it's not changed out. So that is one thing that is very important, to change it out every 4 hours. Also, we have a sleep weaver mask, which is a cloth mask, and we try to consider use of that as soon as possible. So basically, why do we have this protocol? Most of our masks that we use are not made for pediatrics. There's not a wide variety of masks for pediatric patients. Most of our masks are adult masks, and we're attempting to adapt them to our patients. Our current peds masks are the full face shield and the smallest profile light. Before this protocol, the non-invasive ventilation interfaces, along with trachs, were the #1 cause of pressure ulcers from devices that we were seeing in the PICU. Pressure ulcers from devices account for about 60% of pressure ulcers at CCHMC. So this is a big, large number. Once the protocol was put in place, our pressure ulcer rate from non-invasive ventilation decreased significantly. Here you'll see a graph of the pressure ulcer sites from non-invasive interfaces. Most of them occur on the bridge of the nose, where the masks sit, sometimes on the forehead, where also parts of the headgear sits, or the mask, depending on which mask. Those are the two main. Sometimes we'll see it on the cheek or the neck, or the septum, if they're on, again, the cardinal or something like a smaller baby. It really just depends on which masks. So this shows from July 1st, 2012 to June 30th, 2013, that there was 7 unstageable and 2 stage 3s. But then July 1, 2013 to present, we've only had 1 unstageable. So since this protocol, it has really decreased our pressure ulcer numbers. So who is responsible for the patient on non-invasive ventilation? The answer really is that we all are. It's definitely a team effort. Of course, the RTs are the provider that is putting the mask on and taking the mask off a lot. But the nurses are also having to take the mask off. It's really a group effort, and it starts with the whole team. As a nurse, this should prompt you to call your RT if you have any issues, and as an RT, it's important to make a recommendation to the physician if you disagree on what mask or ventilator to use, and then together follow and enforce the use of the non-invasive protocol. For RN and RT, the most important thing you can do is assess the patient together. It's really nice if both go in together, both are looking at the skin, and both work together on a care plan for what is best for the patient. Also gathering up all the products you'll need if there is redness, such as the care dress, the Methylex, the soap to wash the mask out, and stuff to wash the patient's face. Things we still have to work on. There are 2 populations that continue to develop pressure ulcers even with the use of the protocol. There's our #1, infants less than a year. This is basically because There are no real good masks. We've been using nasal masks for full face masks on the infants. We do now have the full face shields in an extra small and an extra small size, and this has helped immensely with our infants less than a year. And then number 2, anyone that's at risk for developing problems such as bone marrow transplant, muscular dystrophy populations, or patients that already have underlying skin sensitivities, it's important that we keep a close eye on these patients or consider, is it okay to do BiPAP on these patients? They're going to have breakdown. Is there another option? The protective devices you may need, here's a picture of that. It's the care dress. It's a sheet form, basically. It's a hydrogel, and it basically provides moisture of the skin to help the skin heal. There's also a gel form. It's called Kerosene, which is available if the hydrogel sheet form is not available. And it's important to place that on the face and then cover it with Mepilex Light as well. And it's important to do this every 4 hours so it does not dry out. Protective devices. We also have a gecko pad. This is basically like a gel pad that we can use under the mask. It's basically the shape kind of that would go right over the bridge of the nose, but it can be cut to fit the patient's face. Especially they come pretty large, like an adult size, but they are able to be cut. They're latex-free, hypoallergenic, and they're great to use for our larger patients. They're very easy to use, but they're very accessible for the smaller patients too. So a good question is, where do we get this protective device supplies? The care dress and the Mepilex are both in the Pyxis machine and the PICU. They can also get obtained from the nurse supplier under hydrogel dressing. The gecko pad is just kept in the respiratory Pyxis and the PICU. So you can ask a respiratory therapist and they can get that for you. The next thing we want to go over is charting the NIV interface in Epic. This is a new way of charting. So basically it is under the ventilator flow sheet, as you can see. And then at the very bottom of that flow sheet, the bottom left, it says NIV interface. And you would want to add the NIV interface. Now on the right side, it says NIV interface. You can see where you can choose from the interface type, interface size, interface model, the headgear, if the interface was changed or cleaned, and the skin intervention. Charting suspected pressure ulcer in Epic is also new. If you suspect a pressure ulcer, you can click on this and click yes. It will bring down a drop-down menu of questions. Answer all of the cascade questions. When you chart no for suspected ulcer evaluated by a wound nurse, a referral is sent to the PAWS team to stage the pressure ulcer. If there's a NIV Skin champion that has staged the pressure ulcer, then chart Skin champion and a consult will not be sent. This is definitely an important feature for the pressure ulcers to get recognized and taken care of quickly. This concludes the education on the non-invasive interface protocol. There will be a post-test available in Elm. Make sure you take this test to conclude your educational session. And thank you for listening.